Good afternoon, everyone. Sorry for a little bit of the delay there. Remember, we're just doctors and health professionals. We're not technology stars, and yours truly was having his own technology trouble. I just want to say good afternoon to everyone. I hope everyone is well. I think most of us are seeing some relief in terms of COVID activity, and I think that's a great thing, although many of our ICUs are still incredibly busy. As many of us have experienced our highest pressures from COVID on this third wave, I'm sure that we all share the same hope that things will continue to improve as vaccination rates increase. During this third wave, I know that my own center had the highest use of extracorporeal life support or ECMO than ever before. As such, a review on ECLS or ECMO is quite appropriate and will be the focus of today's discussion on what is likely our final OC3PR for this academic year. As many are aware, Ontario Critical Care Clinical Practice Rounds, that hard word to say that Neill Adhikari named, or OC3PR for short, has been our ongoing webinar series sponsored by Critical Care Services Ontario to help address concerns expressed by many different health professionals by webinars that will share through learning and demonstration of best practices to help better align Ontario's critical care teams in the care they provide in terms of caring for critically ill patients, be it through medical management strategies or other important issues, including staffing and organization of intensive care units. As was the focus of this year, today's discussion will also be pertinent to COVID-19. As always, we'll be taking questions, which we ask you to send to Q&A. These will be fielded, I believe, by Dr. Josée Thériault and Neill Adhikari, and perhaps by Dr. Mike Sullivan. This webinar, along with previous sessions, are available at the CCSO website and their YouTube channel. As before, I ask that you keep yourself muted. We will also hope that you'll find the time at the end to fill out today's webinar survey, as your feedback is greatly appreciated and will help us plan year 2 of OC through PR. Continue to look for things on CCSO website and consider following them on YouTube and Twitter. COVID certainly has had a profound impact on the world and on the world of medicine. This is certainly true for critical care. We've learned many things and adapted in many unique and profound ways. An area of critical care I suspect that will be changed forever is that of the role of extracorporeal life support, often referred to as ECLS or ECMO for short. For those of us, we have always thought that ECMO would have a greater role in critical care, but it just never seemed to get over that threshold. As we'll hear, however, ECMO has played a significant role in the rescue of many patients with COVID. I think we'd be naive to believe that post-COVID that the role of ECMO will diminish. As experience increases, knowledge and technology improves, the role of ECMO is only likely to increase. As such, I'm delighted that we'll be speaking about ECMO today with Dr. Faizan Amin and with Dr. Eddy Fan, who many of you will recall spoke with us in previous webinars. Dr. Faizan Amin is a cardiologist and intensivist with a focus in advanced heart support and mechanical circulatory support. He's an assistant professor at the McMaster University in several different divisions, including cardiology, critical care, and education and innovation. He completed his cardiology and critical care training at McMaster, followed by a fellowship in advanced heart failure and transplantation at University Health Network in Toronto. He is the medical director of the ECLS program at Hamilton Health Sciences. Joining him is Dr. Eddy Fan. Dr. Eddy Fan is an associate professor of critical care at the University of Toronto. He's an intensivist within the University Health Network. He's a medical graduate from the University of Western Ontario and received his PhD in clinical investigation from Johns Hopkins. He's currently the medical director of the Extracorporeal Life Support Program at Toronto General Hospital. His academic work focuses on advanced life support for acute respiratory failure, as well as patient outcomes from critical illness. Some of the objectives today are to discuss the Ontario experience in selecting and treating severe respiratory failure from COVID-19 with ECLS. Second, the challenges of handling a surge of ECLS patients. And finally, the creation and organization of an ECLS program from the perspective of both an experienced and a newly launched center. Gentlemen, I thank you again for taking the time to speak with us. I believe Dr. Min will be handing it over to you, and I'll be listening attentively. Thank you both.
Thanks, Dave, and thanks for this invitation and opportunity to share the stage with Eddy and share our experiences with everybody, and good afternoon to everyone. I'll start off the talk this afternoon and share some brief slides and then leave a fair bit of time so that Eddy and the team can share their thoughts from both of our perspectives. We don't have any relevant disclosures for this talk this afternoon. Dave, you've already gone through the objectives, so I'll skip over this so we can leave more time in the end for discussion. And obviously, neither Eddy or myself could share our experiences over the last year with ECMO if it wasn't for the tireless work of many other individuals and teams across our hospitals and across the province, really. We've had extenders even coming in from outside our province, so this has really been a concerted effort across the country. But I'd like to specifically thank our surgical directors and all the staff, our physician colleagues within all the different clinical departments, our perfusionists, nursing, RTs, and the rest of the allied health professionals working with us in the ICU. And as you all know, ECMO is very little to do with the technology itself, but much more about the human resources and teamwork that goes into keeping these patients, rescuing them, and trying to get them through to the finish line. So really, it's a full organizational effort from the top down or back offices to the front line. So really a big thanks to everybody for allowing us to and supporting us to serve our patients over the last year and a half. Our experience in Ontario with respect to the clinical experience anyways is what I'll start off with. And our clinical experience has really been very similar to that reported in the literature from across the world. So I'll briefly share some evidence, and that really reflects what we've been seeing in our ICUs in Hamilton, and Eddy can comment as well from their perspective in Toronto. But if we look at what's been published, and obviously there's so much more to learn and more kind of literature to come out of this, but from what we know so far, probably the most sort of high profile paper to date that's been published is that reflecting the ELSO registry data from the summer of last year, published by Dr. Barbero and his group, looking at just over 1,000 patients from Paris in the first wave of COVID-19 across 216 hospitals. And this team evaluated data for just over 1,000 patients, just looking at raw data up to the time to event analysis of in-hospital death, to give us a sense of how these patients were faring in the first wave of COVID-19 on ECMO. And really the high yield numbers from this paper suggested that the survival of these patients was just over 60%, not too dissimilar from data from non-COVID ARDS times with respect to survival on ECMO. Big changes or big differences being a higher rate of complications associated with a longer stay on ECMO, up to several weeks on ECMO, including issues with failure of the oxygenators, bleeding, renal replacement therapy requirements, and intracranial hemorrhages, and multiple secondary infections and other infectious complications. This was sort of high-level raw data. Up until this point, since March of this year, from those centers that have reported their outcomes back to ELSO, to their larger worldwide registry for just almost 4,000 patients, the raw survival or the raw in-hospital mortality is hovering around 50%. And that's kind of close to what we're seeing as well, especially in the third wave in Ontario. Most recently, there was a paper published looking at the data from the first wave in the Greater Paris area a little bit more granularly. This was just over 300 patients, and this team found that in the first wave, looking at the data in a bit more detail, the patients that seem to fare better are those that are younger, so less than 48, less than or equal to 48 years, having a survival over 60%, and even those patients that are approaching 60 tend to have a much poor outcome. And those patients that are cannulated earlier in their course of mechanical ventilation seem to also fare better. And the other association that was found was that centers that were treating patients having had a previous experience of at least 30 ECMO cases seem to have better outcomes than non-experienced ECMO centers. So that's sort of the high-level experience from what we know about the literature to date. And this data suggests that an overall 90-day survival of just under 50%. But I think what we've learned from a clinical standpoint about using ECMO in patients with COVID-19 is treating them similarly to how we treat other non-COVID ARDS patients, using similar indications in patients who fail conventional mechanical ventilation, and those patients that don't have known contraindications. After we've exhausted our conventional ARDS management with deep sedation, paralysis, proning, and so forth. We know that COVID-19 patients treated with ECMO have significantly longer durations on ECMO, and as a result of that, more complications and prolonged stay in hospital even after coming off of ECMO, and their complication rates are high. So ventilator-associated pneumonias, other pneumonias acquired in hospital, and line infections, bleeding, intracranial bleeding, and other types of major bleeding, and need for renal replacement therapy and thrombotic complications as well. So all of these are things that we're seeing and having to sort of try to push through and get patients across the other end. But I think the main highlight of this is we try to consider all of these things before putting patients onto ECMO, knowing that they're going to be on likely for quite some time, and we have to be at least somewhat confident that the patient's going to be able to have a chance to pull through the other side. So appropriate patient selection is, I think, even far more important now in COVID patients than it has been before. And obviously we've been limited with our resources despite ramping up, exponentially. In terms of when to refer patients, these are criteria that reflect criteria that are also published on the CCSO website, and Eddy and the team and us in Hamilton also follow essentially very similar criteria. When we have patients that are suffering with prolonged hypoxemia, reflected by low PF ratios for several hours, in and around or less than 80, or significant hypercarbia, despite doing all our natural conventional ARDS management and using lung protective ventilation and a trial of proning, should be considered, and referred ideally early for consideration for ECMO to your local or regional ECMO center. And in terms of contraindications, really we're looking for any significant comorbidities that would have competing survival outcomes for these patients. So those that are already in shock, already in multi-organ failure, have other kind of chronic comorbidities that would limit their life expectancy. All those things, usually we hesitate to go on to this sort of invasive and resource-intense therapy with known survival that is likely a little bit worse than previously in non-COVID ARDS patients. That's sort of the clinical gist of what we've been practicing and what we've been experiencing, and we'll speak to that more, I think, in the discussion after. I'll speak a little bit about our experience in Hamilton in starting and then ramping up our program over the last 6 to 8 months. And again, I'm thankful to the entire team and the entire organization, and also to Eddy and the rest of the team in Toronto that's been supporting us from even before we started and since we were in the planning phases. But I think our saving grace in terms of being able to support ECMO patients has really been that fortuitously we were actually planning our program well in advance of COVID hitting us. Since July 2019 was when the institutional commitment happened to start supporting patients locally in small numbers and gradually build our experience. And originally the intent, honestly speaking, was to support our cardiac surgical program as we're a high volume cardiac center. So we thought that we would be mainly supporting cardiac patients, yet here we are. So we spent the first 6 months developing a team, developing policies and training, and just before the start of 2020, Eddy and the team from TGH helped us with a multidisciplinary training course for our team here in Hamilton. And following that was when we actually acquired our equipment, did another refresher course through an outside agent. And following that in February, again, fortuitously speaking, we officially launched our program. And I think what saved us was that we spent the time in preparation and focused on having a clear vision and policies and sort of procedures in place. And we weren't intending on, ramping up to this extent. Obviously, we wanted a linear growth in experience, but because we had spent that time in preparation beforehand, I think that saved us and allowed us to be supportive for our patients and colleagues. So for the first few months, we got experience with treating patients on ECMO, both cardiac and non-COVID ARDS. In between that time, we trained more staff members. We focused our efforts on improving our clinical quality and quality of care with case reviews and feedback from the team across the hospital. And then as COVID in the second wave and third wave started hitting our region a little bit harder, we were able to expand our capacity. And as of early January, we were able to register in Critical as a regional ECMO program. And since then, we've been, kind of going strong and steady since early this year. And throughout this sort of timeline, we've been focusing our efforts on continuous education of our staff members, developing ECMO specialists, focusing on policy revisions and polishing them, and collaborating with Eddy and the team at UHN to make sure that we're staying on the right track with our patients and our teams. We're offering ECMO 24/7 on call via Critical, and we're reachable anytime. We select patients through a consensus via a multidisciplinary ECLS triage team, and all patients are accepted and vetted through this team. We use a combined nursing and perfusionist ECMO specialist model, and we continue to transition as best as we can, despite the currently taxing times. Just sort of a brief review, we've continued to expand our capacity and our clinical experience, and the team has done a fantastic job in gaining experience, and I think I'm pretty confident our outcomes will be reflective of that when we go back and review everything in more detail. And we plan to share everything with our Ontario registry as well, and we've registered with ELSO as well to share outcomes with them. So this has been really what's allowed us to do more than 30 cases over the last year, not counting the several that we've put on this week. In terms of, another objective of this talk was to talk about challenges in handling, a surge. I think in Hamilton, anyways, personally speaking, what we had, our challenges were sort of two-pronged in that first we were dealing with, a high rate of community spread and just admitting COVID patients undifferentiated, even those that didn't require ECLS per se in our ICUs. And then in addition to that, we then had to also ramp up our ECMO activity over the last 4 to 5 months, especially in the third wave. And you can imagine that led to a fair bit of chaos within our ICUs, as is depicted by this sort of very spontaneous picture that one of our team members took one day in the throes of the third wave with, just utter chaos. But I think that more kind of organizationally, the team has really come together, and I'm sure Eddy agrees with all the work that's being put in. I think ECMO, perhaps at our hospitals, and I know all the other hospitals in the province and the country that have been dealing with the third wave, especially in how hard it's hit us, kind of reflects sort of all the values that we've learned over the last year and a half of staying strong, resilient, sacrificing, and really putting the team ahead of ourselves. And I think ECMO is a great example of that. There's really no clinical department or area in the hospital that doing ECMO doesn't impact. So it does require a massive sort of multidisciplinary collaboration to ensure that these patients are being supported. Obviously, when we're taking up more human resources to look after these patients, there is a bit of a disproportionate impact on some of the other clinical services, especially in the operating room and other non-intensive care areas. As many of us know, these patients require a fair bit more of physical exertion as well, with all the complications that happen, circuit changes, bleeding complications, continuous kind of keeping families updated, taking patients back and forth to scanners, and so forth. There's a fair bit of physical exertion on top of the moral and mental distress that comes with looking after, these sort of sickest of the sick patients with COVID, many of whom, or most of whom, are really very young, in their 30s and 40s. Along with that, from an organizational perspective, we're already starting with, at least in the third wave, our experience in Hamilton, the biggest challenge was kind of starting with a pre-exhausted group and still ramping up and rapidly up training staff to ensure that we were able to be at the bedside to support these patients. All of that with changing staffing models, as all of us have experienced in our ICUs, just sort of added to the complexity of all this. But again, I think that it speaks to all the values that we've learned over the last year and a half, with respect to teamwork and coming together and being resilient and strong to be able to serve our patients. So in the end, I think that it's really a massive effort on behalf of a huge number of people from both of our and all of our organizations from the top down. In terms of what we've learned and continue to learn, I think most importantly, from a clinical standpoint, appropriate patient selection is probably the most important feature, which is why we, early on in our program at the onset, initiated a multidisciplinary triage team. So we would be vetting cases through a consensus. And we focused over the first 6 to 8 months of our program, and when we had more time than we do now, to really get as much feedback and correct our policies and polish them as much as we could, so that, again, not that we were expecting to ever have this many ECMO patients on in such a short period of time, but because we had that effort already put in, I think it's really helped us and helped us serve our patients better. We continue to keep a registry for all of our patients, which we regularly go back and look at. We've registered with ELSO and are reporting our outcomes back to them to ensure that we're meeting international standards. And again, I can't speak enough to the collegiality that we've had with Eddy and the team, specifically just because of so much of the action has been within the Greater Toronto and Hamilton area with COVID specifically. And there's this constant communication to make sure that we're trying to really support each other's teams. And also to make sure, at least from our perspective as a newer program, that we're on the right track and taking proper care of our patients. And as we do that, we continue to polish and improve our policies and standardize them as we move forward. In terms of where we're heading for our ECLS in Ontario, and I'm looking forward to hearing Eddy's thoughts on this as well. I think what this has highlighted for us, at least in the second and third wave in Ontario, is that we probably need to work on a coordinated, centralized provincial approach to looking after ECLS patients that are referred. Critical is enormously helpful, and I think that as we've initiated sort of an initiative with all the ECMO programs in the province, and look forward to working together more regularly so that we can optimize the processes for patient care, including ECLS transport within our local vicinities. And also focusing on clinical and academic collaboration. And I think, Dave, you hit the nail on the head in the beginning when you said that it's clear that ECMO, with the exponential rise in ECMO use, in not just in the province but worldwide, ECMO is here to stay, and likely its use is going to increase. We all hope not at the same magnitude as we've been dealing with over the last few months, but certainly it's going to be here to stay. And this is an opportunity for us to come together and make sure that we are working together on looking after these patients. So those are sort of the slides, and we wanted to all leave enough time for a healthy discussion towards the tail end of this. So I'll stop my sort of slides over here. Look forward to the questions and discussion.
Excellent. Excellent. Maybe before we go to questions, Eddy, I don't know if you have any comments that you want to lead off with, especially on the Ontario kind of program things, and certainly we'll feed into questions at that time.
Yeah, thanks, Dave, and thanks, Faizan. There's a fantastic overview, and just to thank Faizan and his team. Like, we've really, I think the pandemic has never let a good crisis go to waste, and it's really brought together ECMO programs across the province. We've been all Ottawa, London, us, Hamilton, Sudbury, been in contact constantly, as well as with our colleagues across the country to share experiences, knowledge, and that to improve care and access for our patients. I don't have much to add to what Faizan said, just to say that, again, it's only been possible in this crunch. We've put now to date, I think, about nearly 150 COVID patients on ECMO at Toronto General. And at the height of this third wave, we had 34 ECMO patients in our ICU at one time, which was an enormous burden. And I think the challenge, of course, for all of us in Ontario as well as Canada is that we're reaching the crunch in the third wave rather than places like Italy, Wuhan, and others where their first wave was their crushing surge. Our nurses, I'm sure, and clinicians and staff in the ICU already very tired from 16 months of pandemic, and then to have this tsunami come was really sort of demoralizing and really tough, and really we couldn't get through that without all of their hard work and stepping up for that action. It's really challenged our models of care, our resources, and really forced us to, as Faizan said, to be transparent and clear about decision making on candidacy, and to stick to our guidelines to ensure that we were offering this form of support to the patients that we felt could benefit the most.
That's great. Maybe I'll start off with, nicely said, Eddy, say to Faizan, what was the hardest lesson that you think your team learned starting this? Now, it's always almost trial by fire is what you kind of experienced, which in some ways was perhaps a way of fast tracking a program that could be challenging. But what was the hardest lesson learned? And if you had a do-over, what would you have done differently?
Yeah, I think that the hardest lesson really was the pace of expansion, I think was really what we weren't expecting from a staff standpoint, right? Like, I think there's just so many different disciplines that are involved in looking after ECMO patients that it's really hard to expect everybody to be on the same page all the time. So I think the hardest lessons was that in patients and at the same time, and I think that because our focus as a team when we started, or even before we started our program, the focus was on clinical excellence, more so than just doing cases and adding cases and adding numbers from a surgical or procedural standpoint. So I think the biggest lesson for us was that had we not spent the time in preparing for the first 6 to 8 months, even before we did a single case, we would not have been perhaps as successful as we have been over the last year. Because we had a process in place and clear policies and a clear direction and vision, everybody on the team, I think, felt more likely to be bought in and engaged with the program, as opposed to being a bit haphazard and in a crunch situation. So I don't think I'm positive we would not have been able to do the cases, the numbers that we've been able to do for the sake of our patients, had we not done the preparation up front. If I had to go back and change anything, I would just hope that COVID didn't show up when it did. But ultimately, like I said, and again, this is to no one's credit, but fortuitously, it happened at a time where we were already, getting off the ground. So it's a huge lesson in teamwork. It's a huge lesson in organization, and it's made possible only because everybody from the top down buys into it.
Excellent. Before I go to Neill with some questions, a quick one for you, Eddy, or maybe not quick. Access and inequity across Ontario for access to ECMO. Any ideas on how the province of Ontario, and I'm sure this is true of many regions in Canada, how we can address that? It'll never be perfect. I think we'd be naive to think it, but how can we do that? And maybe that feeds into what can we do as a critical care network to help improve transport to be able to try to address some of those inequities. But any thoughts on that?
Yeah, I think both those things that you mentioned, Dave, are important, because the challenge for Ontario is the geography, right? So our land area is bigger than France. There are more ECMO centers in the metropolitan Paris area than there are in Ontario, probably in Canada. So, and the second challenge is the transport. So at the moment, Critical Orange and our provincial agency is amazing, but unfortunately at the moment, we don't have a lot of long distance transport options for ECMO. So for instance, for the patient who gets into a crisis and could be stabilized on ECMO somewhere, because you have the ability to do that, but then to transport them to a center that can take care of them for the 2, 3, 4 weeks that they might be on ECMO, currently we're sort of limited in that way. So we've been working closely with Orange to try to find solutions, but I would say that both of these things need to be addressed in parallel. I think the province should have a strategy and a coordinated strategy to provide ECMO resources in a geographically efficient manner, right? So we should have centers in the north, the west, the east, and centrally to meet our population needs. And obviously they'll have different volumes, but that's one key thing. And second then is to build capacity, because in most centers, like other regionalized care, ECMO should be regionalized to high volume centers. We know that you need a certain case volume to deliver high quality ECMO care. So we don't want like 10 centers doing 5 cases each. You want 5 centers doing more cases in those centers. So we need a hub and spoke model and the transport capability to transport these critically ill patients to centers, to regional centers that could provide this care. And that's, I think, going to be key, because you're right. Like I remember in the influenza pandemic of 2009, where there was a lawyer for the Ontario government whose wife got sick. And he actually asked a very quick question. If my wife got sick in Cobourg, with the intensivist there known to call you guys to send my wife down to get ECMO. She ultimately survived her influenza after being on ECMO for over 2 months. And the answer at that time I probably would have said is no. Today, I think there's much more penetration and awareness that this is a resource that is available, but certainly it's going to be challenging in various areas of the province to access that care in a timely and efficient manner.
Good. Thanks, Eddy. I think we have a lot of things to do post-COVID with that. Neill, I think you got a couple of questions for our speakers.
Sure. Maybe I'll start with one that relates a bit to referral. The initial part of the question was to comment on an explanation for why patients who've been intubated longer have worse outcomes on ECLS, which was shown in one of the studies. And secondly, and follow up to that, comment on sort of when you're seeing people call you during the third wave. Like, what's your experience been? That have people generally been heeding the advice to call earlier, or if you've been getting a lot of true sort of rescue type calls? Thanks.
Eddy, did you want to take that one?
Yeah, sure. So to your second question first, I would say in the third wave, we've definitely seen many more calls earlier, which has been great. I wonder if that's also partly a function of the fact that in the third wave, many more hospitals were overwhelmed more quickly. And so finding a way to get candidates, those with a very worrying trajectory, out of already very full hospitals was part of it. But we certainly got earlier calls, I would say, when we did in wave 1 and 2. That all reflected, in fact, I think many hospitals, including ours, were seeing that with these variants and younger patients getting sicker, they seem to get sicker faster. That was the other thing. In waves 1 and 2, typically patients weren't reaching the indications that Faizan had put on the slide until usually 5, 7, 9 days in the ICU or on mechanical ventilation. Here, we're getting patients who they were intubated yesterday, and by morning, they're already in refractory hypoxemia and needing rescue. So that might have prompted things as well. For the duration of mechanical ventilation, it's not unlike any other sort of therapy. I like to call this the black hole theory of rescue strategies. Once you cross the event horizon, doesn't matter. The most efficacious therapy in the world isn't going to save you and pull you out of the black hole of death. So the point is that after a certain duration of high levels of mechanical ventilation, ventilator-induced lung injury, injury from the underlying process, COVID, and maybe other concomitant infections or whatnot, the lung becomes so injured that the point that, putting them on ECMO to bridge them to a recovery or some reversibility of that injury becomes very unlikely. And so we have data, observational data, suggesting that the longer you are in ECMO, the longer you have mechanical ventilation preceding ECMO, the worse your outcomes are. And so, and similarly, the 2 large randomized control trials use an inclusion criteria cutoff of 7 days for indication. So that's where our data is. And we have some unpublished data from international COVID data suggesting the same thing, that there's effect modification by duration of mechanical ventilation, so that those receiving ECMO within 10 days of mechanical ventilation have a much better outcome than those for longer. So that's sort of the reasoning behind the cutoff of 10 days.
Thanks,
Thank you.
Neill, do you have another one for Eddy, and then we'll go to Josée?
Sure. Yeah. A question here just around whether the mean duration of ECMO treatment and you touched on this a bit, is longer with COVID than with other than with non-COVID ARDS. And I guess a question from me related to that is whether there's any specific medical treatments that you're able to offer to those patients to help their lungs get better faster. I mean, many of them will have already received some dexamethasone and tocilizumab by the time they get deteriorate and require ECMO.
Yeah, maybe I can start, and Eddy, you can add on. I think it's very clear that COVID patients are staying on ECMO for much longer. On average, at least in Hamilton, what we're seeing is in the order of weeks. So we don't get, we've had a few cases, Eddy, I'm sure you've had the same, they're sort of a week into it, and their ECLS support is weaning, and they start looking like they're going to come off If we give them an extra 1 or 2 days to ensure that they're stable before they come off, they actually, get sick again without any new superimposed bacterial infections. In that, it's a sign that COVID hasn't sort of, the viral illness itself hasn't sort of finished taking its course. And even in patients, I'm sure you've all noticed this as well, that non-ECMO patients that are just treated with conventional mechanical ventilation are also vented for many days, and we're seeing this sort of very delayed lung recovery. So I guess from a clinical standpoint, our lesson has been to sort of keep chipping away and try to treat through as many complications as possible. And so long as we can support the rest of the organs and rest the lungs for as long as possible, there's potentially still a chance that the lungs may recover. So certainly this is a much longer disease course than non-COVID ARDS.
Yeah, I agree. I think the lung has a reasonable chance of recovery. We've seen recovery, again, even in non-COVID patients after prolonged ECMO support. We decannulated a patient after 90 days on an activated trach mask from ARDS. That was one of our longest patients to stay on decannulated. Giving some of these patients who get sort of stuck, as Faizan described, the refractory ARDS type steroids, 2 milligrams per kilogram, and then taper over time. I would say with variable success. Otherwise, it is just as Faizan said, for many patients, it's a waiting game. Many of them do, because they're younger in this wave with fewer comorbidities, like ride it out for a long time with just a single organ failure patient, and without certainly not maybe improving and certainly not worsening, but it's just taking a long time for some of these patients.
Okay, interesting. Just going to go to Josée, see if she has any questions, and then maybe head back to Neill. I think you have a few more, and just cognizant of the time as well. Josée?
Thank you very much. Thank you, Faizan and Eddy, for an excellent presentation. This is awesome. Quite impressive work. We have a question that I think I will direct to Faizan as a new program. And you have mentioned in your presentation some of the areas and the impact on other clinical services. So what are those programs that you saw the most impacted by the establishment of a new program? And with that, where would you see the most relevant investment in HHR and services to support a program?
Yeah, I know it's a great question. I think that for us, I think it's program specific, but certainly we know that to begin with, for a new program, perfusionists are the most sort of ideal ECMO specialists to start off a program and then work on educating other disciplines to become ECMO specialists. So because the perfusionists are shared between ECMO and cardiac surgery, then sort of naturally cardiac surgery ends up being impacted a fair bit by ECMO volumes. If it wasn't for buy-in and support from cardiac surgery, at least locally within our hospital, then we wouldn't have been able to sort of borrow the human resources through perfusion to support our ECMO patients. So it requires a constant crosstalk and sort of planning, human resource planning. And again, it's been a lot of this, because it's been in the midst of a pandemic. A lot of this has been crisis management, which has just been, asking for help from neighboring centers, and even those many outside the province have been helpful in sending us perfusionists and human health resources to help support these patients. So I think, for perhaps new programs that are starting up, there needs to be a clear communication and vision and buy-in from the operating room, from anesthesia, critical care, hematology, and transfusion medicine, essentially there's hardly a clinical program in the hospital that doesn't get either directly or indirectly impacted by a patient going on to ECMO. So even, like infectious diseases, pharmacy, everybody needs to sort of have a buy-in and a stake in ensuring that the patients are going to get looked after successfully.
Thank you. Yeah, it is very much the description of a team-based approach to a program. I would have another question if we have some time. So would you be able to comment, or have you had any experience with the lung transplant for refractory COVID on ECMO?
Eddy?
Oh, Eddy, you're
muted. Yeah, sorry about that.
or censored, I don't know.
Yeah, we've had a few patients who, again, similarly who described, these are young, previously healthy patients. They remain a single organ failure. They're pretty much stuck. CT scanning shows now that they've got worsening fibrosis or fibrotic lung disease following the initial infection and or super infections that have occurred. And so we have transplanted a very small number of traditional criteria for an end-stage lung disease kind of patient who, where the initial etiology was COVID, and they're sort of stalled in their progress on ECMO or on mechanical ventilation or high flow nasal cannula or something like that. So we've transplanted a small number of these COVID recovered patients in terms of the viral infection has subsided, but the sequelae of that problem has persisted in there, and their main limitation is a respiratory problem. So we're still evaluating patients for their candidacy, but just that's an extremely small number of patients and like a rare indication, a rare number of patients who meet that bar.
Certainly raises a lot of ethical and challenges on how you would select and who you would not select. So I'm very sympathetic to you, Eddy, and your team in that regards, because it's obviously not easy. Neill, do you have a few more questions, and then we'll aim to close in a little bit?
Sure. One question on sort of longer term complications in patients that survive ECMO, whether you see things that are sort of unique to this particular therapy, particularly when the duration of ECMO treatment may be more prolonged for COVID than for non-COVID ARDS, or whether it's sort of the usual constellation of problems that they're well described in patients that have been in the intensive care unit for a long period of time.
Yeah, maybe I'll start, and if Faizan has some extra. So, I think we've learned a lot from our colleagues, Angela Chung and Margaret Herridge, who are running a large follow-up study in Canada, the CANCOVE study, and certainly many of our ECMO survivors have been enrolled in that study, and Margaret's been providing great follow-up for us on patients that make it back to follow-up. And so far, at a high level, these patients are basically displaying morbidity and complications that are very similar to other long stay ARDS or critically ill patients. So many of them develop ICU acquired weakness, which leads to decrements in health related quality of life and physical functioning. Some of them will have, unfortunately, neuropsychiatric challenges with anxiety, PTSD, and depression. Some previously, again, we're seeing in this wave, especially young, high functioning, independently living patients who are now having some problems with, executive functioning, memory, and these sorts of things. I would say that Margaret's been telling us all, essentially in keeping with what her previous longitudinal studies of critically ill survivors have suggested, and commensurate with the duration of their ICU length of stay and the severity of their illness. So certainly the ECMO patients being the more severely ill and the longer staying patients, some of the magnitude of these morbidities may be slightly more magnified in them than in a COVID patient who survived but didn't maybe stay as long or wasn't as severely ill at the time of their ICU admission. But I would say that on the whole, we're seeing morbidity that's similar to that of other critically ill patients who survive their ICU stay.
Thank you. Maybe I'll ask one more, Dave, if there's time. And that's maybe for both you and Faizan to comment on what your sense is of how a future provincial ECLS network, what it might look like in Ontario in terms of how do you think patient selection might work? Do you think it would be centralized? Do you think it would be a funnel system to the closest center that's to the patient that's being referred? Some sense of quality measures that's individual centers might sort of sign up to, and whether you think there's that Ontario needs more centers than the ones that have currently developed either before or during the pandemic.
Eddy, if you want to start, I can add on.
Okay, so yeah, I think coordination moving forward is important. And again, I think it's not so much that we need more centers than we need centers that are located strategically, again, for the geography of the province. Like, for instance, Josée and her team have done a great job servicing areas that are more in the north. They've supported very well and successfully some patients. I know they have some on now. I was speaking to one of her colleagues by text in the last few days. But we need maybe some more coverage in the north just to meet, again, the equity for all Ontarians. They should all have equal access to this therapy. So whether we have some centers in Sudbury, Thunder Bay, this sort of thing, that might be important. I think coordination is going to be key, and the ability to transport, as we talked about, will also be important. And I think I would, again, Critical has been a great resource for us in the province. These patients are extremely ill. Transport distances, if needed, should be kept as short as possible. So it would make sense that referrals will be sent to the regional hub center in your geographic area. So, for instance, if you're out east, it might make sense to go to Ottawa. If you're out west, London, centrally to Hamilton or Toronto, in the north to maybe Thunder Bay or Sudbury as a possibility. So I think that would be the way forward. I think agreed completely that, like many things, like critical care in general, it's such an expensive and invasive part of healthcare that we need data to support what we're doing to monitor outcomes and quality. I would suggest that since the Extracorporeal Life Support Organization also has already done a tremendous amount of work sort of harmonizing data and creating a quality improvement strategy and monitoring process metrics, that all ECMO centers should report data to ELSO. And it provides a way to benchmark to like centers, like size centers, like volume centers and that sort of thing. We could also obviously compare our data more regionally in Ontario, as Faizan has sort of described, and we'll plan to do that through ongoing coordination after the pandemic. But I think all of these things would be important as a part of a coordinated ECMO strategy in Ontario moving forward.
Thanks very much.
Lots of challenges ahead. What we'll do is we'll go to Josée for a final question or two. And certainly I'm just going to remind everyone to please take the time to do the survey that we'll put up. Certainly is valuable for us. Ideas for future talks, certainly welcome, and things that we hope to achieve in the next year. So please take the time to fill out the survey that we'll post and send to you. Josée, any final questions that you can ask of our speakers?
I don't have any specific questions, but I really like the aspect of developing the network and having that network established so we can actually share and provide the same care across the province. So that's a very important. And I know, Eddy, I think the province has your cell phone on speed dial. No, Sudbury does. So, and your team has always been phenomenal in helping us manage. And I think we have been challenged from a geography and the small little spoke model we have here, it has basically came from being challenged from a geography perspective and not being able to get patients that make it to us and are too in extremis and make it to a center. So I think that was a program that was built on necessity. Although we really do appreciate, and I think our numbers, and I do agree, numbers sometimes are too small to acquire that maintenance. So I think having that network and being able to share and sharing the knowledge would be very important. So I would welcome that very much. Thank you very much again for your help.
And Josée, I think that is a fitting way to actually end not only today's talk, but certainly the OC3PR. Is it has been incredibly collaborative how the critical care teams at various centers all across Ontario have worked together. We've helped each other out, be it sharing of patients, sharing of resources, sharing of knowledge. And I do think, you know, for ECMO going forward, how could we create a network? How can we build on what we've achieved so far with COVID? It's just incredibly important that we work together, we share resources. Look, we all recognize that resources are going to be challenged going forward. And so how we can best utilize, how we can work together is certainly something I think that would benefit all our patients and create an atmosphere and an environment that's best for all patients. So I think this collaborative, you know, Eddy, you've been a leader in this and helping out various centers. I know you'll do that again. And so certainly appreciative of that. With that, I would also just want to thank both of our speakers. Faizan, thank you for doing this. You know, it's always daunting your first time. Eddy's an old pro here, having done it a couple of times. So I appreciate our speakers and our previous speakers who've taken the time. As you know, we don't pay anyone. And so this is all volunteer work. And so certainly I'm very appreciative of that. I'm very appreciative of the team from Critical Care Services Ontario, CCSO, Maria and Lynn, and certainly have gotten to know you over this last year. We keep asking more of you and you keep, you know, delivering. And so certainly very appreciative of that. I know Mike Sullivan is ruthless at what he asked, but very appreciative of both of you. Lisa and Nancy, likewise supporting this. It's been very uplifting and a positive that in this challenging year that we certainly have been able to do that. Certainly recognize what CCSO has done. That comes from the top. So Cindy, I don't see in my list, but I know you'll probably hear this. So Cindy, certainly appreciative of that. And Bernard Lawless has always been helpful, supportive, and a leader, both in Critical Care Services Ontario and certainly with this. So Bernard, very appreciative of that. I'm also appreciative of the other members of the OC3PR. I'll never forgive Neill for naming that. That's a mouthful that he should have to utter on a regular basis, but he's always driven us with the academia. Josée Thériault has always been there. She also has the line of the year in recognition. I will never hear the word handcuffs again without thinking of Josée, so certainly very appreciative of this. And finally, Mike Sullivan, who's been our fearless leader, has always been uplifting, wise and sage advice for all of us. So certainly appreciate that and has always kept us moving forward. So it's hard to believe what we accomplished over the last year. What started as a low-key endeavor has certainly morphed into something more. I hope it's been valuable for those of you who've taken the time to listen to us. We really appreciate that you have given us feedback and you've participated. We hope it has helped. Like all of you, I hope you're going to take some time off in the summer, get to know your family again, introduce yourself. We're going to take some time off in the summer. Rest assured, if some unforeseen disaster happens, we will make a special exception to make sure that everyone is well informed that we're working together in that regards. We are planning on coming back in September, and we look forward to actually having non-COVID discussions. You know, I think all of us are sick of that word, but recognize it'll have transformed healthcare for all of us. It's impacted all of us. As I say to my kids, you're the COVID generation. We'll always look back at this, and certainly I'll look back at OC through PR as being an important thing, and I hope has been helpful for all. And so I'll leave it at that. I don't know, Mike, if you have any final words, but look forward to seeing and hearing things again in September. Mike, as always, I'll give you the final word.
Dave, you're terrific, and I'm going to use most of my final words to thank you. You've been our front man and here every single time to kind of carry us through. It's been really, really, I think, important. I'm going to circle back just on a couple of things because I think it's been great for us to have ECLS as a kind of final academic year presentation, because it really has been a microcosm of what's gone on with respect to the pandemic. And I think in two ways. One is really importantly, it's talked about system collaboration at a level that we've never been able to achieve before. It's created the impetus for us to do that, and our responsibility is going to be to figure out a way to be able to carry that through as we settle back out of this particular crisis, and hopefully wind up in a better spot than we were beforehand, rather than just rushing to get back to where we were. I think the second part, the intriguing part about this, and again, the exemplar of ECLS, is the possibility that we may find applications for this technology in a variety of places beyond COVID, and trying to figure out how to deliver that appropriately across Ontario, trying to figure out what those indications are going to be. Doing that together, I think, is going to be again, a real positive from this crisis. And so I think that for me is the important thing that I'd like to leave us with. We're tired, and it's appropriate and necessary for us to take some time off. When we come back, we've got to figure out how